Can you hear me, John? All right. Good morning. I'm Dr. Greg Phelps, and I'm going to be talking about palliative care in hospice and the medically complex and potentially life-ending illness patient. So I'm going to go ahead and get started. First, I want to set the stage for those of you out in the virtual world and for the few people here in the audience with some fun facts to sort of see where we're starting from. First of all, Western medicine is reductionistic. There's a part for every doctor and a doctor for every part, but they don't talk well. And I say that as a former hospital medical director who had to live with that. There is little to no integration or synthesizing around the person as a whole, and there's a very siloed approach to how we do medicine. Another important fact is 10,000 baby boomers a day are hitting Medicare age of 65 and will continue to do so for years, and that will be a substantial strain on the system. And just as that is happening, Medicare begins to run out of money in 2026, and will start paying 91% of what the billed or the charged amount is. There's minimal communication between providers in many cases. More than half of patients are medically illiterate. Insurers and others are just now beginning to understand the significance of social determinants of health, and we are just now beginning to bring complex data and projections to target patients who are most likely to benefit from intense disease management. So we need a different approach. We're running out of money and we got too many people. We need to change how we do care. So I've always loved this cartoon. It shows a guy with a Gatling gun as people are getting ready to go out and fight with swords. It means that we need to be looking at a whole different idea. So part of that idea is palliative care, which is specialized medical care for people with serious illness. This type of care is focused on providing patients with relief from symptoms such as pain or stress, and it's to improve quality of life for both the patient and family, and it's provided by a team. So what's the difference between hospice and palliative care? I was asked that as recently as yesterday by a hospital administrator. Palliative care is around that definition of providing extra support. Hospice is a Medicare benefit that most insurers copy that's for the last 6 months of life. So I did my fellowship in Louisville, Kentucky. I learned that all bourbon is whiskey, but not all whiskey is bourbon. So in this case, hospice is basically palliative care for patients with a designated 6 months of life or less.
Half of the link from there.
But it's all palliative care. And the further along we go, the more palliative care we should be delivering. We start off with life-prolonging and quantity of care.
He sent one this morning.
As we go along, we do more and more palliative care until we get to hospice, which is all palliative care. And even at death, we continue in hospice to provide care for the family for 13 months afterwards. One of the things that's important to know is that all life is limited. My favorite joke is that life is a terminal illness, and it's sexually transmitted. So hang in there. But end-of-life care is part of health care. All patients at some point are going to pass, and we need to be working in that understanding, but there are powerful incentives, both financial, emotional, and whatnot, to keep people from focusing on that fact. So what do we not teach medical students and residents to do? This is a quote from the 1800s. I've often thought it is more important to instruct physicians how to behave in cases of incurable disease, not so much to tell them what to do, but what not to do. So my least favorite phrase when I'm called in for a palliative care consult is I come in and say, I'm Dr. Phelps, I'm from palliative care, and the patient hangs their head and says, I know, they said there's nothing else you can do. And I say, oh yeah, there's stuff we can do, I just can't cure you of your illness. So as Hippocrates said, cure sometimes, treat often, comfort always. And we have frequently gotten away from that. So there is never, ever nothing else we can do, ever. There is always something we can do. Palliative care is holistic. It's integrative. It's synthesizing. I stole these slides from the Center for the Advancement of Palliative Care, and it talks about making cancer into reminding them of the dancer that patient is. Chemotherapy, mother. Palliative care sees the patient beyond the cancer treatment, beyond the treatment for whatever illness they have. What does a palliative care doctor do? I was asked in an elevator during my fellowship, which was only about 10 years ago, what do you do? And I kind of went blank, and the elevator went ding, and the person got off while I was still struggling for an answer. So I said, I got to work on my elevator speech. And so what I came up with was the 3 C's for palliative care. That's comfort, communication, and coordination. Comfort is being experts in relieving symptoms: pain, nausea, shortness of breath, spiritual angst, depression, constipation, nausea, vomiting. And we do that quite well. Communication, experts in communication with patients and their families around diagnosis, prognosis, and treatment. I was involved in an ethics case yesterday where the fundamental fact was that the family did not understand the patient was not going to get up and walk out of the hospital no matter what happened. And so palliative care was called in to talk with the family about where they were and what the likely outcomes were. And then once that's been explored, is what are we going to do with that? We want to get on the same page as where the patient is and then where the family is. And so often we see patients that are sick and tired of being sick and tired, and they just want to be comfortable, and their family is willing to put them through god-awful treatments to try to keep them alive for a few more days that the patient doesn't particularly value. Our unit of care is the patient and family, and we work as a team. So this kind of sums it up, and this was a revelation to me. I am a family doctor by background, and I grew up in the curative model, and then learning palliative care was kind of a revelation. So in the curative model, the goal is to cure. We treat the disease. Symptoms are treated primarily as clues to diagnosis, and the primary value is placed on the lab test, so we don't really care what the patient has to say about how things are going. Test devalues the patient's subjective experience, and therapy is indicated if it alters or slows the disease progression. Patient's body is differentiated from their mind, and the care is reductionistic. Now, I speak from personal experience, and I'll say a word about how a simple turn can change a life. My mother was in China on the Great Wall, and they were filming a commercial as she was coming down, and somewhere along the line, 2,000 years ago, they had built a turn into the stairs, which my mother didn't see because she was looking over the side at the film, and she fell and broke her hip. And she was eventually brought back to the U.S. where she had hip surgery, and she had every known complication. She ended up with 9 different doctors. And so as her son and also the hospital medical director, I would get conversations from the doctors on the same day that went, "Your mother's dying, I'm so sorry," to, "Hey, everything's looking pretty good." And you try to sort out what's going on in that, and I'm at least medically trained, but for the families to try to deal with this storm of everybody looking at their one little part and giving an answer based on that really does not serve the patient or the system. So in palliative care, the model is to relieve suffering. We treat the patient and their family. We treat their symptoms. We value their experience. We look on them as complex, social, physical, emotional, spiritual beings. One of the things I like most about my work is I work daily with chaplains and social workers, and we delve not only into the medical issue of what pill is the patient taking, but how are they coping, how is their family doing, etc. The treatment is congruent with their beliefs, and it's integrated for the whole person. And where death is the ultimate failure in curative care, enabling someone to live fully and comfortably until they die is considered a success. So there are 8 domains of palliative care that include physical, psychological, social, spiritual, cultural aspects, along with care of the patient towards the end of life, and ethical and legal aspects. I just wanted to mention that there is a underlying substrate of process for what we do in palliative care. And since I'm giving this lecture from a hospital, I had to include this cartoon. Hospitals are not benign places, period. Bad things happen, and they happen for trivial reasons. I have a dear friend who recently came into the hospital having chest pain. He was supposed to have a catheterization. They brought him breakfast. He ate it. He didn't know he wasn't supposed to, and so he had 5 days of additional risk for his heart because they then ran into a holiday weekend. So hospitals are not good places to be. There is something called hospital-associated disability. People over the age of 70 get this. People over the 85, more than half of them get it. And what it is they acquire a disability where they're in the hospital. And of course, we know ADLs are dressing, bathing, eating, taking care of yourself, and people lose these things in the hospital. And a third of patients in the hospital also develop delirium. And what frequently happens, I've been a patient in the hospital, you get no sleep, the food's bad, you get medications that disturb your equilibrium, and over several days of no sleep, even the soundest person will begin to get a little crazy. So the important part in HAD, or hospital-associated disability, is 41% of those people died in the following year, and 29% were still disabled at the end of that year. So being in the hospital and getting a disability is not a good thing. So when to think about palliative care. Dr. Johnson's going to hate me for this slide because he's the palliative care doctor. But it's the surprise question. Would you be surprised if this patient died in 18 months? Some people say 2 years. Hospices, would you be surprised if this patient died in 6 months or less? Frequent admissions, coming in and out, going back and forth. We track patients readmitted from the skilled nursing facilities in our palliative care service, and what we see is there's only one nursing home in the greater Chattanooga area that's within the federal guidelines for how often patients should be allowed to come back. Most of them are anywhere from 30 to 50%. Complex care requirements, home feedings, oxygen, decline in function, moving in or out of the ICU, initiation of dialysis or ventilation. I was at UT Medical Center in Knoxville for a number of years, and we had a required protocol. If somebody was going to start dialysis, that they had to have a palliative care consult to see if that's what they wanted. PEG tube contemplated. That was an ethics consult just this week about, was this a good idea? Pain or symptom control, goals of care. And now with big data, we're talking about artificial intelligence, we can look at large populations and pick out the patients that are most likely to need intensive management with palliative care. And we're currently engaged in a trial program with doing that with an area ACO. And EPIC can actually adjust likelihood of the patient returning to the hospital. So using EPIC, one can look at the patient population and say this person has a 30 or 50 or 60% chance of returning to the hospital. That's good data to be able to pick those people out before they come to the hospital and start doing more intensive management. So prognosis, talking more about data. We stink as doctors. Nicholas Christakis wrote a book called Death Foretold about how little we know about prognosis, and he came up with the unofficial physician norms. Number one is don't make a prognosis. If you have it, keep it to yourself. Don't be specific. Don't be extreme. Be optimistic. But the data shows we are wildly optimistic to the tune of 3 to 5 times too much. And that has not really improved much in recent years. So what's it all about? We are perfectly unprepared for something that is totally predictable. Everybody's going to die at some point, including me. So let's talking about the end-of-life care. Now, I may be dating myself with this song here, Cause of Death. Patient laid down the boogie and played that funky music till he died. California Healthcare Foundation survey of 2012. Patients who would like to talk to their doctor about end-of-life wishes, the short answer is about 95% would. Ever had a doctor ask about end-of-life wishes? 92% said no. Most patients would prefer to die at home, only about 30% do, and most patients say they would prefer to have a natural and peaceful death. Only about 7% of patients are saying they want everything done till they have their last possible breath. But the system is not geared to do that. So we need to be better communicators. And when I did my fellowship, I spent a year learning how to be a better communicator, how to talk with patients, how to use ask, tell, ask, how to explore things. And I will tell you, before that, 40 years ago when I was in my family practice residency, I was carefully schooled in how to guide the conversation so that it lasted the minimum amount of time and the patient was not supposed to talk much, but I could get on to the next patient. So we've had a reverse in how we should be having these communications with our patients. And communication is one of the 6 core competencies according to the American Medical Colleges. So it says, I'm sending you to someone less squeamish to tell you what you've got wrong with you. Communication, 70% of adverse outcomes are poor communication. As a hospital medical director, I have seen that in person. 2 out of 3 patients discharged from the hospital without knowing their diagnosis. I thought this was wrong until we actually went out and interviewed patients who'd returned or readmitted within 30 days and interviewed them and said, what's going on? What did you have? And they said, I don't know, but I'm back again with it, whatever it is. 60% of patients misunderstood their instructions. Physicians waited an average of 18 seconds before interrupting a patient, and doctors only introduced themselves 1/4 of the time. When I was at UT in Knoxville, it was an academic medical center, obviously, and the patients never knew who their doctor was. The person they were most likely to know who was caring for them was their intern or resident, and they had no concept as to who else was doing it. So a survey of attitudes from the Center for the Advancement of Palliative Care. From the patient's side, the concerns were cost, control, communication, choice, and cure. Physicians not providing all options. You know the phrase, to a man with a hammer, every problem is a nail. Doctors not sharing information with each other. Doctors not choosing the best option for seriously ill patients. Patient and family leaving not knowing what they're supposed to do more than half the time. Patient lacks control over treatment options, and doctors don't spend enough time talking and listening to patients and family 50% of the time. When I was the medical director of the hospital, I had a family come in and complain that their doctor never came to a complete stop in their room, that he would come in spouting lab stuff, talk about what was going to happen next, and exit patting the patient on the shoulder. And I knew the doctor, and I said, does he wear a white coat? And they said, yeah, and I said, grab it. They did. He came in the following week, I guess it was, to share his lack of enthusiasm for my intervention. He says, I was in there an hour trying to explain to these people what was wrong with their mom. And I said, you probably needed to be. It probably would have worked better if you'd done that sooner. And he said, well, don't ever tell somebody to do that again. I told you instead. So, talking about end of life, since I don't have a large audience here to pick on, what do these four women have in common? From upper, let's see. There's my mouse. There we are. Nancy Cruzan, Karen Ann Quinlan, Terry Schiavo, Brittany Maynard, all young women who are dead, and they made case law in their dying. And the point is that it's not only old people like me that pass away. It was, what are their goals? What were their desires for treatment? Did they ever said, boy, I would never want to be on a ventilator, something like that. I had a real case, a patient who was, we were consulted on. They were on an Impella, CRRT, and a ventilator, and I met with the family and asked them how they thought things were going, and they thought things were going pretty well, but they wanted to make a very important point early on, and I said, what's that? And I said, Dad would never want to be on life support. And I almost laughed. I said, you understand your dad is on multiple forms of life support, plus he's 94 and has dementia. I said that his heart's being beat for by him, his kidneys are being done by him, and the machine's breathing for him. And they went, oh, he'd never want that. Can we stop? So we talked about it for a while longer, and that was eventually where we got to. So 3 levels of conversation. Young and healthy. How would you like to have your life go? And when you're young and healthy, you're willing to accept a lot less in terms of quality of life. As we come up on Thanksgiving and Halloween and the holidays, when you go home and talk to your family, there's one of our 2 preferred holidays. That we call it Turkey Day. Some people call it Thanksgiving. You'll be with your family. You'll have the opportunity to maybe have some adult beverages, good food, family, and you can say, hey, this crazy doctor gave a talk about how we should talk about our end-of-life wishes, and here are mine. Then when you get older, 55, rising, encountering serious illness, time for that talk again. Encountering a likely life-ending or life-threatening illness and reviewing your choices and preferences, because our perceptions of what we're willing to live with and what we're willing to put up with change as we get older. So advanced care planning, begin with the end in mind, to quote Stephen Covey. What are your goals? How do you want to live? Paint me a picture of how you want to see your life. What's important? What do you want for your family? How do you want to be remembered? At hospice, we use a booklet called 5 Wishes. It says the things I would wish my family to do, to know, to care for, to speak for in my care. There is also online, advanceddirectives.tn.org. You can pull up the form. You can designate a surrogate. You can say what you would like to have done and not done. You have 2 friends witness it. It doesn't have to be a lawyer. You don't need a notary. You can have 2 friends witness it, and you are good to go. Also, as an added benefit, if you want to see the benefits of gastric sleeve surgery, they have the before video of me giving a talk about that on the website. So, end-of-life discussions. This is hard. It is really, really hard to sit down and tell somebody that they're going to pass at some point. Now, the ideal thing is to have this conversation long before you need to. When I was a family doctor in rural Chester, South Carolina, I'd occasionally have a patient, I'd do a physical exam on them, and they'd say, so am I going to live? And I go, well, no. And they go, what? And I'd say, not forever. And they go, oh, okay. I went to go visit a friend yesterday. I was wearing my lab coat. It said palliative care. I walked in, and his son had a come apart because, oh, my God, I didn't know it was that bad. I said, no, I'm a friend. We're here to talk. So end-of-life discussions. They did a survey with cancer patients. 332 patients with a terminal illness. Have you or your doctor discussed any particular wishes you would have about the care you would receive if you were dying? Now, the important thing to know was these patients all had stage 4 cancer. They were dying, but only about a third of them knew it. And if they'd had that conversation, they got less aggressive care, fewer ICU admits, fewer ventilatory episodes, and aggressive care was associated with poorer quality of life for the patient and didn't really change the outcomes. And they found that patients did not become depressed. They did not lose hope. Those surveys were baked into the study as it was going along. So how not to tell a patient bad news? Hop, jig, dance, prance, I've got cancer. This is the palliative care procedure that I spent a year learning, was how to have a goals of care discussion, how to talk with the patient about their impending demise. It is much better to have at home or in the office well before anything becomes substantive. Remember that any of us can pass at any time. If you listened in on phone calls with my family, when we get done, we usually say goodbye, I love you, because we never quite know when that's going to be the last time we get to say it. I had personal experience with this. Fortunately, it turned out well. Had that conversation with my my wife. And then my daughter called me a little while later and said, Mom's having chest pain. We're going to the hospital. She thinks it's indigestion. And then I'll call a little bit later. Her troponins are positive. We're going to the cath lab. And a little bit later, I hope you're on your way. We're going to bypass surgery. So she ended up doing well, but you never know. So goals of care discussion, pre-planning and semiotics. Semiotics is the study of meaning. What you do says so much more than what you say. Sitting down, silencing your cell phone, turning off your beeper, pulling up close to where you can make contact with the patient, knowing the patients, the pre-planning, introductions. Remember, I said only a quarter of doctors introduce themselves, and usually patients forget your name in that stress. So I will usually say, hi, I'm Dr. Phelps, and I will hand them my business card so that they have something they can look back at. We try to have the whole team that's caring for the patient in there. The nurse that's caring for the patient, if there's a social worker or chaplain that needs to be there, the treating physician, if at all possible, but frequently the treating physicians will leave that to palliative care. Sometimes that can be well. During my fellowship, we had one surgeon that showed up 5 minutes late as we were doing the introduction, said, I don't know why I have to be here. Your mother's dying. This doctor's going to take care of it, and walk back out. Made the rest of the conversation a little more awkward. We're here to talk about your mom's care, your dad's care, how we're doing, or your care if you're able to have the conversation. Tell me a little bit about the patient. You'll say, well, he's got stage 4 cancer. And so I read that in the chart. Tell me a little bit about him as a person. What does he like to do? What do you like being with him? What kind of scares you? Tell me what you hope for. What do you understand about the diagnosis? Remember, I said that patients are medically illiterate. So they can maybe parrot the diagnosis but not understand the implications. I had one family tell me, they say Dad's got a neoplasm in his thorax, but thank God he doesn't have lung cancer, to which I unwittingly responded, that is lung cancer. And so, or they may tell you, I had one patient tell me their dad had adenocarcinoma of the pancreatic head. And I said, what does that mean to you? Because it was right. I said, I don't know. That's what they said. I memorized it. So you know where you are, and we use a lot of ask, tell, ask to make sure that the patients are with us. So at this point, we usually fire a warning shot, something along the lines of, I wish I didn't have to have this conversation. I wish things had turned out better. I wish your dad had bounced back like we'd hoped he would. All of these are to set the stage for pay attention, I'm about to ruin your day. Explain the diagnosis. Don't use words of 3 or more syllables. You break it down for the patients, and then explain the implications. I had one patient that he told me, I came in and said, do you understand what you have? He said, yeah, I've got stage 4 lung cancer. I said, affect is not matching the diagnosis here. And so I said, let's break this down a little bit. You said you've got stage 4, and that's what the chart says. Yeah, it says, okay, so stage 1 is a fairly tiny little dot. Stage 2 is it's bigger. Stage 3 it's starting to spread, and stage 4 is it's really spread, and there is no stage 5. He goes, oh my God, the doctor told me the stage 4 like he was telling me the weather. They didn't explain the implications. I was like, you're right. And then the next thing is in the oh my God is await the reaction. Now, we as physicians, particularly male physicians, I'll pick on myself, really don't do well with strong emotions. People tend to cry, shout. I've been threatened with 3 malpractice suits at that point. But you have to stop and listen. Let them say what they need to say. Validate their emotions. I can see you're angry. I can see you're upset. I certainly understand why you would feel this way. If they threaten to sue me, I say, I can see you're really angry. This has all been very frustrating. If you need to sue me, we can do that later. But today, now, I need to know what we're going to do with your dad as we go forward. So far, that has worked. Keep the focus on the patient. Did your dad ever talk about what he would want? Does he have an advance directive? And if the family starts banging the table and say, I want for my dad, we say, but what does your dad want? If he could get up and walk in here and whisper over your shoulder, what would he be saying? Because we're looking for substituted judgment. We talk about CPR. I could do a whole talk on just CPR. Well, I prefer AND, which is allow natural death. There was a guy who won the Nobel Prize for economics related to a book called Nudge that I highly recommend. It's actually written for a general audience about choice architecture. Patient's coming in at 2 in the morning and you're the hospitalist and you say, hey, if your heart stops, do you want us to restart it? Yeah, sounds reasonable. Hey, you've got stage 4 lung cancer. Your cancer is spread. You're getting close to the end when the time comes. Do you want us to keep you comfortable and allow a natural death? Yeah. How you phrase the question, how you have the conversation makes a huge difference in what response you get. And then summarize and record what you did, because inevitably what we call the dreaded child from California will show up the next day having taken the red eye and make everybody's life miserable. And so you want to know who's talked to, who's the designated surrogate, and who's making decisions. The goal of a care discussion is the success is based on how much the patient and family talk, not how much I talk. My job is to ask the questions for them to get to some resolution, along with information that they need to get there. So, we're not God, but it is not enough to treat and treat and treat. If a family and patient are willing to listen, they need to hear likely outcomes. I was working with a very demented patient that was getting dialysis, and the family was debating about stopping, and one family member said, oh, no, he's going to be okay. And I said, well, tell me a little bit about him. And he said, oh, he was a farmer. He loved to be out in the fields. And I said, oh, that's nice. And I said, so what do you think is going to happen? And he said, I think he's going to go home. I said, so you're thinking he's going to be walking out in the fields and the sunlight coming down and whatnot? I said, yeah. I said, no, never. I said, he can't walk. I said, we can roll his bed to the window and he can look out, but I'm not sure, based on his cognitive status, he's going to understand what he's looking at. Oh, well, he wouldn't want that. Now we're getting somewhere. So giving the family a feeling for what the future is likely to be like. Now, I have a gazillion jokes about doctors who have overstated their case, patients who've said that, my doctor told me I had 6 months to live, and then here they are several years later. But oftentimes when we say we can treat, what the patient is hearing is we can cure, we can make this better. So we need to be explicit about patients. I had one patient who happily told me he was getting palliative chemotherapy to cure him, and I said, no, that's not how it works. Palliative care is trying to buy you some time. He said, oh, I'm pretty miserable. Can I stop? And I said, you could, yeah. So one of my heroes in this field, and I have a list of books that I can recommend at the end, is Atul Gawande, who wrote Being Mortal. It says, we've forgotten how vital such matters are to patients as they approach life's end. People want to share memories, pass on wisdoms, keepsakes, and connect with loved ones and make some last contributions to the world. And when we in medicine deny these patients these moments out of obtuseness or neglect, it should be a cause for our unending shame. Why don't we talk about advanced care planning? I believe the patients have trouble discussing death. I've actually shown you a slide that says no, they would like to. I have trouble discussing death. If I talk about your death, I'm acknowledging possibly my death. I'm not sure what to discuss, document, and I don't get reimbursed. It's amazing. There are now codes to get reimbursed, but it's amazing, according to Medicare, how little they're used. We got the stigma with Sarah Palin's death panels and whatnot, but there are now codes to pay for patients to get have this conversation. And here they are, 99497 and 99498. So if you have a conversation with a patient for 16 minutes, that's the minimum, you can add on the code for having this conversation. If you go 46 minutes, you can add on additional codes. Minimum documentation, time in, time out, person designated to make healthcare decisions, who participated in the conversation, what was discussed, what documentation was or was not done. How often can you do this? Well, I don't recommend it, but you can do it daily. There is no set limit to who can do it or how often it can be done. As long as the person is able to bill Medicare, that's licensed clinical social workers, PAs, nurse practitioners, DOs, MDs, then they can bill for doing this. And you don't have to complete the form. Sometimes you have to initiate the conversation and then come back a day later or at the next visit and continue the conversation. A little bit more about prognosis. This is what we call the palliative performance score, and it starts over here. Hopefully all of us are 100%. Ambulation is full, no evidence of disease, doing self-care, normal intake, normal cognition. You go down and over, but you never go back up. And this has prognostic significance, and the ability to walk, excuse me, is the most important part, and then evidence of disease by what they're restricted from, and then what they can do self-care-wise. Now, I throw in a caveat on the self-care and the ADLs because patients lie. If I say, are you continent? They will be offended and say, yes, I am, and their spouse is going, So it's important, is to quote Ronald Reagan, first we try, then we trust, to ask them to do that. So if I say, can you walk to the end of the room and back? Sure, have at it. You learn a whole lot when you do that. I've seen patients sit and rock in the chair for a while and say, well, I just don't feel like it. And say, I learned something. So prognostic significance to this, PPS of 40 or 50%, chance of being dead in 6 months is 80%. And I'm not sure I can back up. I'm going to try. There we are. 50%, mainly sitting and lying, unable to do any work, requires assistance with self-care, but still eating and still normal cognition. So now if they're drowsy, they're down to 40% or further on down. So, and going forward again, PPS of 10%, when I've done an admission for hospice and they say the patient's PPS is 10% and I get to my computer the next day, the first thing I do is not do the certificate of terminal illness. I look to see if the patient's still alive, because more than 50% of the time they have died in the intervening 12 hours. This is the ECOG score, which is the reverse, where 0 is good and 5 is dead. And the important part here is ambulatory, capable of self-care, but unable to carry out any work up and about more than 50% of waking hours as related to the tumor. Now, I joke that my ECOG score is at least a 3 because I spend almost all my time sitting at a desk or sitting in my car. So it's related to the illness. And then 3, I lost my cursor, is in the bed or chair more than 50% of the time, and that at that point their survival is estimated at 6 months. This is specifically for cancer patients. So conditions with approximately a 50% mortality in 5 years. This is important to know. Heart failure. A study of cardiologists said only 13% were comfortable discussing end-of-life wishes, although it's recommended for patients with heart failure. I can't tell you the number of times I've had patients with heart failure who've said, well, they say I've got a little bit of heart failure, but I'm okay. And I said, well, having a little bit of heart failure is like being a little bit pregnant. You hang in there, something's going to happen. So, and if patients know they have a 50-50 chance of being dead in 5 years with an illness, they are much more likely to either start making other plans or being more cooperative. We're working on a program when I left Knoxville where the first time you came in with heart failure, you got the standard education. The second time you got a little more intense education. You got home health care to follow you. The third time you got a palliative care consult, and the fourth time you got a hospice consult, because every time you come into the hospital with heart failure, your life expectancy goes down by half. End-stage renal disease, study of patients starting dialysis, only 6 out of 62 had a discussion about prognosis, which includes 25% mortality in the first year. COPD, similarly. In solid tumors, 37% of patients had a discussion about prognosis, as I mentioned in that other article. Metastatic non-small cell lung cancer. Palliative care actually extends life. they did a regular care plus palliative care. The palliative care plus patients lived an extra 3 months. They also had less chemotherapy in that process, and they did better. Diane Meyer, down at the bottom, is the patron saint or godmother of palliative care. She's a geriatrician and palliative care doctor in New York City, and she said survival times were improved as patients were helped to avoid preventable hospitalizations and fruitless chemotherapy. The recommendation from the American Society of Clinical Oncologists, you do the best chemotherapy, then you do the next best chemotherapy, and then you do the next best chemotherapy, and then you talk clinical trials. I've had patients come in that have been on 7 different regimens, and that's not even their own specialty society does not recommend that. Prognosis, malignant hypercalcemia. Patient comes in unless they've got new breast cancer or myeloma, and they come in with a calcium of, say, 13, and they say, Dad's acting weird, and you get the total body CT scan, and you find his kidney or lung cancer. Their prognosis is 50% chance of being dead in 4 weeks, 49.9% chance of being dead in the next 4 weeks. Multiple brain metastases, 1 to 2 months without radiation, 3 to 6 months with radiation. What is multiple? 2 or more. Malignant ascites, malignant pleural effusion, malignant bowel obstruction, all less than 6 months. So, and I will mention that if you go to cancersurvivalrates.com, boy, somebody's working to find that website, you can look up, plug in the numbers, and see what the survival rate is. Now, before I get angry letters from oncologists, I will say that some of the new immunotherapies have altered some of these outcomes, but it's usually an N of 1 or 2. It is not across the board. So for the most part, some of these therapies in some patients can give them another year or so of life. There are very few patients that are cured even with the newer therapies. Heart failure, I mentioned the falling life expectancy, so I'll skip on. Actually, patients in hospice have an 81-day advantage in being in hospice to not being in hospice. So here's what happens in cardiac illness. They start having sudden declines. This is COPD, heart failure. They'll be bumping along, then they'll have a catastrophe, they'll recover, they'll have another catastrophe, they'll recover, until eventually they pass away. When to think about hospice for heart failure patients? Poor response, class 4 symptoms, at rest or minimal activity. An ejection fraction of less than 20 is helpful but not required. History of refractory arrhythmias, and patients should not be thinking about bypass, transplant, LVAD, resynchronization, etc. for hospice. Now, we actually have a patient with an LVAD who has passed his 2-year mark in our palliative care program. End-stage renal disease, creatinine clearance of less than 15 with diabetes, without 10, and they're not choosing to do dialysis. You cannot be in hospice and be getting dialysis at the same time for the same diagnosis. COPD, classically these patients are still smoking. They're little skinny, usually little old ladies. They're on oxygen. They smoke till they get so dyspneic they can't stand it. They put their cigarette out, please, and then they put their oxygen on, get their breath back, light up, and go back to it again. They will frequently have an O2 saturation of 88% or less off their oxygen. They're frequently losing weight. They're tachypnic and tachycardic, and they're also usually losing function. Dementia. You have to be pretty demented to be in hospice, usually becoming incontinent or losing the ability to speak and walk, along with comorbid conditions. So what happens to the elderly? If they have the conversation, they go into hospice, survey of 4,000 patients, most of them don't come back to the emergency room, and the majority die at home, which is where they wanted to be. If you don't have the conversation and tell them they have a fatal illness, they keep doing what they've been doing because that's what they've been doing. So 75% come to the emergency room in their final 6 weeks, more than 50% in the final month. A lot of them get admitted to the ICU, and they die in the hospital where they could have been home had they had the conversation. Just a word about cost for palliative care. 25% of Medicare spending goes to the 5% of patients who are in their final year of life, and most of it does not seem to have much benefit. Kind of like in cancer, there's a U-shaped pattern where we spend a whole bunch of money at the beginning and a whole bunch of money at the end and not as much money in the middle, and the whole bunch of money spent at the end really doesn't seem to alter the outcome. This is why hospitals administrators like palliative care. This is admission following on day 7, day 10, and day 14 palliative care consult. on average, patients start making different decisions about their health care. Not all, but some. So that's about end-of-life care. Now I'm going to press on to a little bit on symptoms, and then we'll be done. So there's a lot of suffering that goes on at the end of life. 70% of terminal cancer patients suffer pain. Most of it's unnecessary. They also have delirium, shortness of breath, fatigue, bowel obstruction, nausea, vomiting, depression, spiritual angst, and that's what we're there for, to try to help with the symptoms. Now, we're also in the midst of an opioid crisis. It says we have two public health crises going on, the undertreatment of pain, and the other is prescription drug abuse. And we paddle on one side of the canoe for a while, and then we paddle on the other side of the canoe for a while. But palliative care and hospice are specifically excluded in the state of Tennessee from the opioid regulations around pain clinics. So our motto is whatever it takes. State maximums of 100 milligrams does not apply to hospice patients or palliative care. There is no functional ceiling on pain medicines. Let me say that again. There is no functional limit on pain medicines. So, to put this in context, as a hospice doctor, my world's record for a patient was 1,000 milligrams of morphine IV an hour. That's what it took to control the patient's pain, and they did not die. So, usually 2 to 5 milligrams IV every 4. So just to kind of put it in context, when I say there is no limit, I mean there is no limit. Some patients, however, can get hyperalgesia, which is the more pain medicine you give them, the worse their pain gets. So I see that maybe once a year, and it's important that we be cognizant of it and back away when need be. We talk about the ethical rule of double effect. If my goal is to do a good thing for the patient, i.e. relieve their pain, but they could also die from having their pain relieved, that is morally and ethically acceptable as long as I'm following appropriate guidelines. And I bring this in to say that pain is not a pressor agent. We don't make patients suffer to keep their blood pressure up. I've had in the hospital, the patient was moaning in pain, dying, and I turned to the nurse and said, let's give him 5 milligrams of morphine IV. And she said, oh, I can't do that to be my license. I said, no, he's really in pain. And she said, well, he could die. I said, probably not from 5 milligrams, but the other thing is, I'm a hospice doctor. We're expecting death. The question is not if, it's when. So we want it to be when he's comfortable. And she continued to refuse, and I ended up giving the patient the morphine, getting him comfortable. He did not pass away immediately, as she was afraid of. I wish I could spend more time on this slide, but I can't. But you need to know that there's a way to translate one opioid to another. And oral route versus IV or sub-Q makes a difference. So briefly, 30 milligrams of morphine, which is our common language. If you check the CSMD website at the end, it'll have down what the patient's oral morphine, or sometimes they call it medical morphine equivalent is. And this is what they're talking about right there. If you give it IV or sub-Q, it becomes 10 milligrams. That's important. I've had doctors say, give them 2 milligrams of dilaudid IV, PO, sub-Q, whatever. Well, there's a huge difference in how that works, because if you look at dilaudid, 7.5 milligrams, if you give it IV, it equals 1.5. So there's a difference in how the route works. The rest of this, and I'm more than happy to send my slides to whoever would like to have them, is knowing kind of how to translate in between. Timing of medicines. Time to onset to peak IV is 10 to 15 minutes. That doesn't mean if you give it, you're not going to feel funny in the first minute or two, but it will reach its peak effect in probably 10 minutes or thereabouts. Sub-Q, 20 minutes. By mouth, 1 hour. Fentanyl patches can take 12 to 16 hours, and that can be a catastrophic problem because the patient puts one on, waits a couple hours, says, oh, it didn't help, puts another one on, waits a couple hours, oh, it didn't help, puts another one on, then the first one kicks in, and before they wake up, they've died of an overdose. So you need to know that. And most medications, the short-acting ones, oxycodone, dilaudid, plain-acting morphine, oxycodone, only last about 4 hours. So there's what they call end-of-regimen failure, where patients will say, those last 2 hours, because the prescription's written every 6, those last 2 hours, they have more pain. And so you have to know that when you're prescribing. But TennCare, last I checked, will only pay for 4 short-acting pills a day, so everybody assumes that means that that's how long they last. Medication should be given regularly and routinely. If it hadn't worked, if you give it IV, it hadn't worked in 15 minutes, it's not gonna. Do it again. Same thing for by-mouth medication. If you give it and wait an hour and it hasn't worked, Waiting 5 more hours is not going to improve the outcome. You need to get on top of the patient's pain rather than wait for pain pill, pain pill, pain pill. If you do pill, 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 they suffer less, and they also have, by some studies, some less pain. So we do 3 prescriptions in hospice and palliative care. Long-acting, because you've heard the no pain, no gain. Well, our motto is no pain is no pain. So we use long-acting to try to keep the patient from having pain. We use short-acting for what we call breakthrough pain. And then this is really important. You have to have a bowel regimen. If you write a prescription for a patient for an opioid, it's guaranteed constipation. And I have lived through this personally. It has to be a stimulant laxative, not Miralax, not lactulose, Ducalox, or Senna. So you would start a patient who's opioid naive on maybe 5 milligrams of morphine Q4 hours scheduled and Q1 hour PRN, and tell them just take that every 4 hours, and if you have additional pain, regardless of when you took the other pill, take the PRN dose. And then add it up. We'll say they took 6 5-milligram pills scheduled, and they took an extra 6 PRN. So that's 30 milligrams and 30 milligrams. So you would write a long-acting prescription for 30 milligrams MS Contin twice a day, and then use 10 to 15% of that total dose, which is 60 milligrams, as a breakthrough dose. Now this is fuzzy math, so it doesn't have to be, there is no 6 milligram pill, which would be 10%. 9 milligrams would be 15%, so you'd probably go with a 10 milligram pill. That's just to give you a feel for how to do pain medication. Adjusting the dose, patients will rarely notice less than a 25% change. So if their pain level is a 0 to 3, spike the ball, do the happy dance, you're good. 4 to 6, you may want to go up 25 to 50% of their total dose. And if it's severe pain, go up 7 to 10, you adjust the dose up 50 to 100%. And that's taking all the medicine, the PRNs, the short-acting, saying, okay, they took 100 milligrams of morphine total in short-acting and long-acting, and their pain's a 10, you could go up to 200 milligrams of long-acting pain medicine. Now, I would suggest consultation with somebody else before you do that, but the first time I had to do it, I was convinced I'd killed the patient, was up all night worrying about it, called the patient the next day, he answered the phone, at which point I sagged with relief, as, hey, it's Dr. Phelps, just called to see how you're doing. He said, Doc, this is the first time I woke up not moaning in pain, thank you. So that's how you do it. If the patients are taking more than 3 breakthrough doses, you should be looking at more long-acting medicine. Oops, I'm going the wrong way. There we are. Okay. Other things, because it's not all opioids, tricyclic antidepressants, seizure medicines, gabapentin, Lyrica, SNRIs, venlafaxine, and Cymbalta. Oddly enough, hypnosis can help. I mean, I have used that sometimes. In a previous life as a small-town country doctor, I learned to do hypnosis, and it's time-consuming, but it can work very well. Music therapy, spiritual counseling, whatever. A few words about delirium. This is actually something we deal with more than we do pain. This is an acronym, you know what they say, HCA-TMA. Healthcare has too many acronyms. But this one can help you remember the things that can cause delirium, including the medications I give, including pain medicines and anticholinergics. They can sundown. They can have low oxygen related to a stroke, heart attack, pulmonary embolus, infection, UTI, pneumonia, retention of urine or stool, undernourished, underhydrated. They could have a metabolic deficiency, or they could have a subdural. Because a lot of little old people are on warfarin or Eliquis, and they fall and they bump their head. They say, oh, no, I'm fine, I'm not hurt. And then a week or so later, that steady drip, drip, they say, oh, Mom's getting close to the end. She's not doing as well. So my bedside delirium workup is checking for fecal impaction, checking for urinary retention, checking skin turgor, looking at the medication list, and asking if they've had any falls, however slight, in the last week or so. We try to do non-pharmacologic treatment first, and we do a terrible job at this. I was in a hospital where Karen was my doctor for 4 days, or my nurse for 4 days. It remained the 4th of September for the whole time I was there. Nobody ever did any reorienting, but those things are important. And they kept me up every night. So I was surprised I didn't get delirious myself. And then Haldol. People think, oh, the people were agitated. Let's give them lorazepam. Bad idea. It's like giving them alcohol. Haldol or other antipsychotics are the drug of choice. Haldol is cheap. It's effective. It has minimal cardiovascular effects. It comes as a liquid. It comes as a pill. You can give it sub-Q. You can give it rectally. And the maximum dose goes up to 100 milligrams. I've never given anybody 100 milligrams. I'll usually start with a little old person, 0.5, wait an hour, give them 1, wait an hour, give them 2, wait an hour, give them 4. I've never gotten past 4. So if somebody is agitated, that's the way you would prefer to go. Since we're coming up on Halloween next month, I had to throw this slide in, nausea and vomiting. That's for all the fraternity people who are having COVID parties. Lots of reasons to have nausea and vomiting: vestibular, anticipatory nausea, infections, dysmotility, chemoreceptor zones by toxins and chemotherapy. And they did a study. They did a really big workup on the people who had nausea and vomiting, trying to figure out exactly what was causing it. And the other group, they gave them Haldol, and the results were the same. The people who got the Haldol did as well as the people who didn't. So it's also a great drug for nausea. And no, to answer the question, I do not own stock in the company that makes Haldol. I don't know what company does make Haldol. But if it doesn't work, try a prokinetic drug like Reglan. Then you can try an antikinetic drug like Levsin, but obviously don't use them at the same time. Zofran can be helpful. Marinol can be helpful. Tennessee is not a medical marijuana state, but I frequently tell patients in hospice, just don't do it while I'm in front of you. But Haldol touches on the D2 receptors, the anticholinergic receptors, a little bit on the 5-HT3, so it's kind of a good for what ails you sort of medication for nausea. That's why I usually start with that. Constipation. Remember I talked about a stimulant laxative there? Usually we use Senna, which is over the counter. It's dirt cheap. And the old-timey prescription is, and this will make it memorable for you, 2 of these in the PM for a BM in the AM. You can go up to 8, and then I start adding in the lactulose, the Miralax, and stuff like that to soften the stools up. Don't use fiber. It tends to result in concrete, so we don't use that. And, of course, we try to avoid Fleet's phosphosoda because most of our patients are elderly with compromised renal function. Lubrication, Docusate. I was at a hospice convention, and they had us taste all these different things. And without a doubt, Docusate liquid is the worst tasting. And there's actually something called the Bristol Stool Scale. You can look it up. Somebody came to a Halloween party one time with that on their T-shirt. It talks about how much, what you're trying to do is get more water into the stool so it's softer, and they discovered that Docusate adds 0.01% water to the stool, so it is essentially worthless. So anytime I see somebody on Docusate, I will stop it. It can also, this is a fun thing in hospice, we will make Vaseline balls, chill the Vaseline, roll it into pills, roll it in powdered sugar, and give it to patients, and it works fairly well. It lubricates the intestines. Dyspnea is a mismatch between effort and perceived oxygenation. I always say, think of people who just ran in the Boston Marathon. They're staggered across the finish line, and they're doing, they're dyspneic, but they're oxygenating really, really well. So you want to look at fluid overload, consider diuretics, sitting patients up. Fans help stimulate the trigeminal nerve and help relieve breathlessness. Consider opioids, such as morphine. I asked a cardiologist one time, at what point do you start your patients on morphine for their dyspnea? He looked at me like I'd asked, when do you prescribe arsenic? He said, never, never, never. And I said, well, you know, your patients are suffering, and this is an opportunity to get them to feel better. Depression, the surprising thing is most patients in hospice are not depressed. I kind of figured 100% would be, but it's only about 50%. Best question, have you felt down, depressed, or hopeless most of the time over the last 2 weeks? 100% sensitive. Of course, it takes a little more nuance to explore it after that. And frequently, the complaints with depression are similar to the complaints of the illness. Fatigue, poor sleep, loss of appetite, loss of energy, things like that. But here's a difference from where we in hospice and palliative care treat depression. Ritalin is our go-to drug. If you use a tricyclic or a SSRI, it could take 5 to 6 or more weeks to work. If you've got a patient who's got a life expectancy of 4 weeks and say 2 weeks after you're dead, you're going to feel less depressed, that would be a true statement. But so we use Ritalin 2.5 to 5 milligrams morning and lunch, and the effect can sometimes be amazing. I had a patient who was literally laying at the bed, not talking, tears rolling down his face. His wife said, his sons are coming in to say goodbye this weekend. Is there anything you could do? I said, well, we could try some Ritalin. And she called me the next day and said, oh my God, he's sitting up on the side of the bed, he's laughing, he's talking. We can't stop this, we got to keep him going. So we did. But they can work in 24, 48 hours. And then if they do have a longer life expectancy, you can later transition them to a more traditional antidepressant. We do use Ativan for anxiety, but not for agitation. Anorexia, I call this the wife's complaint. Make him eat. I knew he loved me because he ate my food, now he won't eat. I had one wife go so far as to say, I want to put a feeding tube in, we're going to grind up my food and make him eat it. And I was like, a little over the top. So dietary consultation, Marinol helps a little. Megace, I think, is close to worthless. It has a lot of side effects. Dexamethasone is actually my go-to drug of choice. It gives the patients a sense of well-being and improves appetite. And I'll do it for like 5 or 6 day bursts of 4 milligrams. Morning and lunch are just 4 milligrams a day, and patients will usually feel a good bit better. We don't do a lot of parenteral nutrition in hospice or palliative care. But getting the patients to eat, I tell them I don't care about fat, sugar, cholesterol, salt, unless they're heart failure. Eat whatever you want. If ice cream sounds good for breakfast, lunch, and dinner, like it does for Joe Biden, I'd say go for it. Few closing words. One is, this is an article also by Gawande in the New Yorker called Overkill, and it's about how unnecessary care crowds out necessary care, particularly when the necessary care pays less. And in a single study, 42 to 25% of Medicare patients received at least one of 26 useless tests and treatments. And when Gawande read Gilbert Welch's book, Less Medicine, More Health, he said, that's BS, that can't be right. So he went to the charts on his desk, he went through his charts, and he said he was actually closer to the 42%. Said millions of people are receiving drugs that don't help them, operations that won't make them better, and scans and tests that will not be beneficial. Common thing we do with patients with heart failure, 85 years old, come in, their ejection fraction is 25%. The cardiologist, oh, they need an AICD. They put it in, they don't get any better. We come in as hospice and turn it off 2 weeks later, $40,000 down the drain. But nobody really talked with the family about kind of where this is going, and is it time to have the conversation about letting go? Pill burden. Chances of getting a drug-drug interaction hit 100% or 99.99%, somewhere between 7 and 8 pills. There was an article in the New York Times just last week about over-medication, and that our mindset is still we got to prevent, but then we start ending up treating a side effect from one medication with another medication that causes another side effect. So we do a lot of deprescribing of medications. And let me see if it's on the next slide down here. I love this website, the number needed to treat, vnnt.com, tells you how efficacious medications are. It's affiliated with the Cochrane Reviews, but how many people do you have to treat? Osteoporosis, prevention, 50 people have to take aldichronate or another bisphosphonate to avoid a fracture, 50. If they've had a fracture, 16. Cholesterol and statins, number needed to treat for primary prevention of a non-fatal MI, 60 patients over 5 years. 98% what we're doing and when we're doing it. Do statins save lives? Absolutely. My wife is on a statin. She is on her 3rd statin because she keeps developing muscle problems and whatnot. So what do we do with failing patients? Honest conversation. I love the let's stop telling the public that exercising and eating blueberries will keep people from getting old and frail. Better advanced care planning, care delivery in the patient's home, and a care system that embraces long-term supportive services. In talking with patients, honest questions are always acceptable. Empathy, compassion, listening. They don't have to have all the answers. In 1994, only 3 medical schools taught courses on religious and spiritual issues. The last survey that I could find was 2004, and about half did. Here's a reading list. Being Mortal by Dr. Gawande is at the top. I couldn't not leave in that I had a book come out recently called Education of a Hospice Doctor. For the residents in the audience, When Breath Becomes Air by Paul Kalanithi. He was a neurosurgical resident who developed lung cancer and passed away. His widow, who was an internist, finished the book for him. I had the opportunity to sit with her and chat for a while at a conference about a year ago. I mentioned Less Medicine, More Health, and a book about having the conversation by Angelo Volandes. And with that, I've got some resources, and I think I have, I'm 1 minute over. So thank you for your time and attention. I hope that was helpful. Going back up, I do have an email. If anybody wants to give me a yell, I'm more than happy to do it. And I wanted to call out for all the residents and students, this is an app on your phone. 405 different things related to hospice and palliative care, usually one page, curated, referenced. If you need to know quick how to prescribe methadone, it's got it. You want to take somebody off a ventilator, quick, it's got how to do it. This is really handy to have, and I have it on my phone. So thank you very much. Gee, we need an applause track now. Thank you. And